Hello, this is Dr. Hausinger, and this is the PowerPoint for Chapter 10 of your Van Wormer book, Social Aspects of Addictions, Family Risks, and Resiliencies. So when we look at addiction, we have to look at how it affects the entire family, whether we're looking at it from a disease perspective or a biopsychosocial perspective. Okay? And there's pain and stigma associated with having a family member that has an addiction. Okay? In box 10.1, I encourage you to look at the Des Moines Register, Children of Addicts, looking at specifically in Iowa some of the things that have happened. And we've mentioned this previously, but different drugs do affect children in different ways because of the characteristics of those drugs and behaviors and risks associated with those drugs. So, for example, alcohol might have a different effect in the family than methamphetamine does. Okay, and also we need to look at the legality of whatever is being abused. Okay, so in the older model, we're looking at the addict as a symptom of the carrier, and that family communication and that there's faulty communication in the family, such as anorexia. So what we want to look at, and if we're looking at family systems, is that the person with the addiction isn't causing the problems. We have this living organism, this system in which we have a domino effect. How one person acts is going to affect the rest of the family. Okay, so we don't blame the addict for having an addiction and saying that they've ruined the family. We have to look at the dynamics of the family as a whole and look at it holistically. So that goes into, is there a confusion of cause and effect? What is caused the addiction? What's causing the dysfunction in the family? Was it the addiction? Was it the family system to begin with, etc.? So unfortunately, and I think that we're changing this because more and more people are coming to get CD certificates, but in the family therapy field in general, there's not a lot of education or attention to addiction problems except as symptoms, and we need to look at it in terms of how it affects the dynamics of the family. Okay. And there tends to be not a lot of attention to cultural diversity, which is something that we also need to look at. So going back to our healthcare system, a lack of insurance has prevented the emphasis of family treatment. What does that look like? How are we getting treatment? Who is being treated? So it really looks at the addict as the person that needs treatment. Most inpatient rehab programs do have a family program of some sort. Generally, families come on the weekends and hear lectures and might do family counseling with a counselor. Okay. Virginia Satir and Claudia Black, two pioneers in the family addiction field. We look at the family roles of the addicted family. Claudia Black is from the Seattle area, and she specializes with children. And we have this idea that, oh, it won't happen to me. And we develop this, I don't talk about it, I don't trust people, and I don't feel. And that's where we might have family systems where we have two alcoholics, or the non-addict is addicted to the person's addiction, otherwise known as being codependent. As a response to this, Al-Anon developed in the 1950s. It's really a sister program to AA and the 12-step programs, which are, of course, for the person that has the addiction, whereas Al-Anon is for the family members who love the person who has an addiction. Okay. So we have different roles that seem to come up in addicted families. We have the person that might be codependent, also called the chief enabler. These terms can have negative connotations later on, the big C word, codependent. And there's a lot of, their recovery program is built around codependency, as well as some great books and resources. Okay, so in a strengths-based perspective, we might use the term family manager instead of chief enabler. Okay. Wegscheider's term for family roles include the hero, scapegoat, lost child, and mascot. And children in an addicted family system can cycle through these roles. They're not static. We also see it as if an older child goes away or if a child dies, this kind of shifts throughout. Okay. Right. Melanie Beatty popularized the term codependency no more with her book. However, your author suggests survivor instead of codependent, because that does have negative connotations. So, family manager and survivor. I like loved one personally. Okay. So, some of the things that you're going to be looking at today are family systems, and we can look at the family forms. An enmeshed family, there's a couple different options. Spouses are estranged, and one child here is enmeshed with the father, one with the mother, which really affects the child's individuation. Another term for this can be emotional incest. It's not necessarily sexual incest, but it's where the child becomes a co-parent and they forfeit their childhood because they become an adult. So that child might go to family functions with the non-addicted parent or non-afflicted parent and fulfill roles as confident. They might have more information they should about the family finances, etc. And we find that the older children of enmeshed families, they tend to become counselors. In an isolated family system, we have a lack of cohesion and social support, and people are kind of floating around, and each member is protected by a wall of defense. So if we look here, there's no individuation. We might hear the term helicopter parent or, smother mother, that type of thing. And here, everybody's kind of off in their own stratosphere, and we have the opposite problem. In a healthy family, we look at interdependence, right? So we have some good, healthy boundaries here. You see that everybody is their own person and the walls support each other, but we have boundaries that are not overlapping. And that's what we are really aiming for, individuation and interdependence. Okay. So we've talked a lot about the stages of change in our program. We address it a lot in 401. And it's not just for addiction. It can be for any different type of behavior change that a person might want to make. And you're going to see this a lot with motivational interviewing. So the first stage is pre-contemplation. And even though this is in a list format, it's actually a circle and it's fluid and a person can go in and out of it at any time. So in the pre-contemplative stage of change, counselors describe family communication patterns so that there might not be a problem or everything might be blamed on the addict. In the contemplation stage of change, family concerns are looked at. We do see that maybe male partners might be difficult to engage because of shame and guilt and social stigma. In the third stage, we have preparation, which is where the breaking point, we might have a formal intervention, but family members make a list of feeling responses to the addict's reactions. We often see change with addicts when the family unites and comes together and say, this is what I'm no longer willing to accept. These are the things that I am willing to accept. In the action stage of change, we have the rehearsal and treatment of family without the addicted member. So we might do role play here, and we might practice what we want to say. Okay. And then we're looking at how the family roles operate within the system. In the maintenance stage, we're looking on the process, not the content, because life goes up and down. And we might have family contracts at this point. We might have emergency plans. Everybody should be doing their self-care. Okay. And then hopefully we have a transition with sobriety. The family can heal too as a unit, even if the addicted person is not ready to make a change. So I want to be very clear with this, that the person doesn't have to get sober for the rest of the family to do their own healing. And oftentimes that is not the case. When looking at cultural considerations, there are things that work with different races and ethnicities. Okay. With African American families, looking at reciprocity as a strength, also looking at extended kinship networks and family raising the children. In Latino families, it's important to be more family oriented and avoid the business like approach, which can happen. And again, this really goes back to healthcare because it is run as a business in the United States and it's not run as a social services. In Asian and Asian American families, we need to look at the hierarchical structure and engage the most powerful person in the family, maybe a matriarch or a patriarch. Right? And I would say with Native American families, it's very important to bring in the elders as well. And you're going to see with different races, ethnicities, and cultures that we're going to have maybe 5 people in the room, or 6 people in the room, or maybe even more, which is great, and we want to play upon those strengths. Another example would be Appalachian families. We want to look at the women who are going to take care of the health practices of the rest of the family. So it's region specific as well. Okay. One of the things that I recommend that everybody looks at sometime, if you can get some domestic violence training, or at least look at the Duluth power and control wheels, they can be really helpful. There absolutely is a connection of substance use and violence. We know that the majority, 80% or more, of DV situations do involve alcohol. And when alcohol and cocaine are used, they metabolize down into a very nasty substance that can cause blackout rage. And we see that with a lot of domestic violence situations as well. Right. Not the biggest fan of the term battering. A lot of professionals are kind of getting away from that. But there's more movements now about male-focused programs. I really recommend anything from Dr. Jackson Katz. So if we look at battered women programs, that's the problem. Battered women, we don't talk about the batterer, right? So there needs to be something there to address the perpetrators, not just the women. So when we talk about domestic violence, we usually talk about the survivors and not the perpetrators. And Dr. Katz says that really domestic violence is a men's problem because it's the men that are perpetrating this. And of course, we do need to talk about the same-sex couples as well in LGBTQ. But in general, we're seeing more male on women violence. Okay. We can use motivational interviewing as the bridge between women's domestic violence services and substance abuse treatment. Okay. Again, no wrongdoer to treatment. And we can teach women safety plans for harm reduction. It's not uncommon to have some type of contract, a safety contract, and we can put substance use in there, especially if the partner is having afflictions like that as well, or if substance use does influence the domestic violence. Okay. And where substances are involved, we have a serious risk of violence and death. You may have heard the term beer muscle. Okay. So fair fighting, we could also rephrase that and rename it as assertive communication. We want to attack the behavior and not the person. So a lot of this is assertive communication, and we use assertive communication when we work with clients, especially families. So a lot of what we do as drug and alcohol counselors is teach people new ways of experiencing life and new ways of communicating. So instead of saying, you're a drunk and you're an abuser, you could say something like, I feel very afraid when you drink because you get violent. Right? So we want to attack the behavior and not the person because we're not going to get anywhere. It's also counterproductive and potentially dangerous to argue with somebody that's under the influence. So in a situation where there might be domestic violence, the best thing to do is to get out of that room or out of the house. And we want to be very careful about being in rooms where there might be objects like knives. Like, you don't want to have an argument in a kitchen. We want to reduce means. Okay. When working on issues, we want to not bring up everything in the past, but work on things that are manageable and avoid labeling. Okay. And stay in the present. And it can really help if you have a mediator. So a lot of what we do in family drug counseling is this, but also teaching people. If they are just used to blaming and throwing things, we have to model and teach and help people practice new skills. So we have the 3 R's model, which is easy to use and to remember. Rename. We're not using labels. For example, looking at shopping addiction as an illness. You might not like the word disease for addiction. We did debate that. You could use the word illness. Okay, so call it for what it is. Right? Shopping addiction as an illness, not foolish spending. Okay, reframe, help the client see things happen for a reason. This is really part of cognitive behavioral therapy and motivational interviewing. And then reclaim, looking at the healing process, not getting mired in the muck, but moving forward, looking at the we and the collective as the family, especially with Native Americans. All right. So one of the things that you did in this course is, or will be doing, is drawing a family genogram. And you can also look at the roles in your family and looking at, communication patterns. A relapse prevention plan, we look a lot about this in 401, and this is going to be different for everybody because everybody's relapse triggers are different. And then other things that we can do are there's some great material out there that shows like what is it like for somebody coming out of rehab, with some vignettes, especially if a family member is unfamiliar with addiction and they don't know what it's like. That can be very challenging. With the family relapse prevention plan, going back to that, sometimes we do contracts, especially for adult children or young adult children. Is there a curfew? What are the expectations? Are you going to pay rent? What are the bottom lines? Are you allowed to live in the house when you're recovering, etc.? Okay. And then what is the relapse prevention plan? And put it somewhere visible, like on the fridge. So addiction really thrives in isolation and shame. So we want to bring it out of the shadows and expose it into the light where we can move forward.